So it's my pleasure to introduce Dr. Walter Wodchis. Walter's a scientist at ISIS and a professor at the University of Toronto in the Institute of Health Policy Management and Evaluation, among other places. Walter's going to tell us about HOBIC acute care reports, which I hope all of you received. Was it about a year ago now? Yeah, just about a year ago now. Walter?
And I just want to thank the HOBIC team who've been working very hard at ISIS to help enable us to have data that we can share with you in a way that will be meaningful to you, I hope. And there's going to be a little bit of interaction. I don't know how it'll work with the camera, but we'll work it out. So this is the core team at ISIS that are really supporting a lot of this work. Doran is up all hours helping to ensure that we have the right data presented here. Xiaomu Ma ensuring that we have the right numbers underneath. Peggy, Ian, and Penny are absolutely every step along the way helping to guide our work. I'm going to make a few introductory comments because the discussion hopefully will liven up at the end and I won't have time. I do a lot of performance measurement and performance management in the healthcare system. And the critical gap in performance management and performance measurement is people will say, okay, we know those are good measures and we need to be monitoring them in the health system. But if we're actually going to make improvements, getting this data a year ago or using the administrative databases that we have, that's not going to serve our purpose. It's not real time. The real difference here is HOBIC offers an opportunity where we have a solid performance measurement system that is also real time. Assessments are coming in every single day to ISIS. You have assessments in your hospitals every single day and across the system and sectors. So we actually have an alignment of the same information that will support both performance measurement and quality improvement. And that's a pretty rare find. So I just wanted to highlight that. Another thing I wanted to say is that last time we had some slides here, about a year ago, we had just over 17 sites of data with historic data that we were able to report on. Now we have 17 large hospitals and another 36 small hospitals, 53 in total I'll be presenting information about. That is an astronomical increase in 1 year's time in terms of the data that we can present. I looked, the average monthly intake now for these data are 6,500 individuals every month are receiving HOBIC assessments. That's not everybody, and I'll talk about who we're getting and not. But that's a pretty rapid rate that we have that kind of information across the province on 6,500 patients each month on a real-time basis. Today I'm going to talk a little bit about helping to use the data to advance practice and evidence for reporting, so what we can do around the reports, an overview of what we're going to send to you, and I'm really hoping to get some feedback on this today. Some things we heard from last year, so I think we're in good stead, but we're also trying some new ideas this year. And I'm hoping that that will then lead to some discussion about what is most useful to the individual sites and hospitals. So just to start as a background, the reason most of you are probably here is because HOBIC is very useful. It can be used to monitor and improve your organization's compliance with required organizational practices. Assess the impact of quality improvement initiatives implemented in your organization, and that's the emphasis I want to put, is how you can use it in real time. And then help you to better understand patient outcomes and larger trends with the larger data about what are the important factors and where are there good opportunities for improvement, which sometimes just following an individual patient is hard to see. But if you can step back and look at the system and a population, you can see where those opportunities are. Which patients have good outcomes or suboptimal outcomes that can be improved. And then comparing results with peer organizations. I think that offers clear opportunities for where individual organizations can know where they can improve. So the kind of data I'm going to present today will be hopefully fairly straightforward and simple. The first baseline piece of information, both from a research and a performance and a practice standpoint, is what's the coverage of our population? How representative are the data? So what proportion of patients discharged from your hospital are currently assessed with HOBIC? So here's a value add that ISIS can offer you because we can look back at the entire discharges coming out of the discharge abstracts and then look to linking the HOBIC data to see, so what's our coverage here? how many of the patients being discharged and recorded do we also have assessment information about. And then the assessment completion is another important aspect. There are admission assessments and discharge assessments, and if you want to monitor and track changes over time or performance of the organization in a way that can inform quality improvement, both need to be available. I think in terms of long-run outcomes, and a lot of the research that I've been doing with the data use primarily the discharge assessment, but you're going to see other research here that looks at the internal organization processes that can improve the change, the improvements over time. And then finally, we'll look at some individual results. So today we're going to pepper the presentation not only with the broad provincial view, which I think we did last time, but we're going to bring it down so that sites can see the kind of data that they themselves will be receiving. So the evidence for reporting, and I won't spend long on this because I think Dot's done a fantastic job of covering both the history and the evidence behind the measures that sit in an old, not that old, but for a young guy like me it's old, report by Doran et al., a study of nursing-sensitive outcomes data and in acute care and long-term care settings. And this study found that outcome tools were sensitive to change in patient conditions. So that is, in a lot of measurement systems, the most difficult thing to achieve is measures that are sensitive to change and are reliable. And it was sensitive to change in functional status, symptom frequency and severity, pain, nausea, dyspnea, fatigue, and therapeutic self-care. And if we think about the quality measures that physicians are using, they're not so much the symptoms, they're much more diagnostic-based or procedures or interventions. These are the things that are really important, though, in terms of both individual patients' well-being and the causes that they will often present to a hospital, as well as other care settings and their care-seeking needs. Data collection on these nursing-sensitive outcomes can be done in a reliable, valid way. And that's what we really need to continue to strive towards improving as well. So ICES will be sending out reports to each individual site that link this HOBIC data with CHI discharge abstract data to understand the coverage, assessment completeness, and change scores for each participating site. You already have reports about some of the change scores. We'll include some of that information again, but one of the key advantages to this reporting is that we can have the linked data. We outline here some key reporting metrics with the purpose of obtaining feedback. So I'm here because I do want to hear from you about, there's a forced choice question at the end too, so you have to respond. So what I'm going to do, I'm going to do some coverage by hospital type that I've talked about, then by some major clinical categories, both that I think have practice meaning and also have some policy and accountability importance. Looking at some change scores. Then looking at the ADL change scores, which we highlighted in last year's report, we're going to revisit this. But this year, we're actually also going to be including a new focus around therapeutic self-care. Last year at this forum, I presented on some results that show the importance of therapeutic self-care on discharge and readmissions to hospital, an important area, I think, of concern everywhere. And we're going to focus in on some of the ways, and that's where I'm going to get your feedback on how we can best present this information to you. So coverage. This is an example, a sample site of a small hospital that started in the early days of HOBIC. So they were here right at the very beginning. And the light blue line in the middle, this pointer won't really quite show up. The dark blue line in the middle shows the average of all sites from the beginning. So this particular sample site started in April '09. So you see they had no assessments until April '09. And then they come up. And then you see they came about 85% of their hospital discharges had been assessed with the HOBIC instrument. These particular tables show either an admission assessment or a discharge, so some assessment was done on the individual and entered in the data that we have. And then you can see that this hospital kept up over time. These are, if you get used to using these, there's a little bit of fluctuation month to month, but you can see the bands are fairly tight. Most small hospitals, so this also shows the benchmark against other peer hospitals, so small ones. There's a dotted line that shows the 75th percentile, so 25% of small hospitals are achieving rates of coverage at 95% or higher, which is pretty fantastic. And then you can see also over time that the variability among hospitals has narrowed. So there's more consistency and uniformity in the implementation of HOBIC, particularly among small hospitals. And 75%, the bottom shows the lower quartile range, so 75% of hospitals are above that bottom quartile. And so 75% of hospitals, small sites, are achieving better than about 76% coverage, which is, so in the small hospitals are actually a lot, they're very, very useful information and I think that's to the advantage. Larger hospitals have more challenges. They have higher flow, faster throughput often, and so you can see the overall rates are lower. They're also probably more specialized procedures. We're trying to understand exactly which patient populations are not covered as well. But again, we see pretty much reasonable stability. This is a large site that came on in December 2008, and then immediately there was great enthusiasm. We can see over time that they haven't been able to quite maintain their enthusiasm, although they're still within the band of the practice medians and across the province. So here's an opportunity to kind of see where are you as an organization compared to the average, compared to the top and lower achievement organizations. And the other thing is that the bands here are actually slightly widening, I think, because we've also particularly expanded our coverage of large hospitals. So I think that will be true, and hopefully they will also narrow over time, as we saw with the smaller sites. This is for the entire province, overall coverage by hospital type. So this is among all patients being discharged at the hospital site. And here we're showing, and you'll also individually within your organizations receive these kinds of breakdowns. So the average is ranging around the 70% coverage, and this goes medical and surgical, slightly lower in the surgical outcomes. But not that far off. And then the 25 CMG group, so some of you may be familiar that LHINs now have accountability agreements with readmission rates for a subset of 25 CMGs. And so this being relevant to the hospitals, most of these being cardiovascular or GI conditions. There's a short list, very important, I think, to the ministry, LHINs, and hence to organizations in the health system. And we see, again, similar coverage rates for all the populations. So it's uniformly being implemented, I think. So here's the assessment completeness information that we'll present to you. So the first column shows across the main scales, so these are the main outcome measures that we've been talking about. How many had, so the far left column is complete assessments, both an admission and a discharge, exactly as we'd expect. And then we show what percent of the, and this is also very recent data, so we're showing you the most recent, not an annualized. So this is from the fall of 2012, which is, goes to show the rapidness of this data turnaround, right? Like this is data that you're actually looking at from your most recent quarter. Missing admission assessment only, so you had a discharge, missing the discharge only, so you had an admission, and then what percent were missing the admission and discharge. So these rates are about 2% lower than they were last time we showed this slide, although we had a longer period of time. We had the whole year's data before, so I'm not sure about the exact comparability, because it could, as you see, they do fluctuate over time. But there are still some challenges in ensuring that patients are admitted and assessed with the HOBIC, and again assessed on discharge. So there's pretty good coverage. You can see missing both an admission and a discharge assessment around the clinical measures that are most important to nursing fatigue, dyspnea, nausea. They are very few are missing both those assessments. So they are getting assessed. But if the absolute completeness of the data is still lacking. That's definitely true. About a quarter to a third of individuals are either not getting an admission or not getting a discharge assessment. And that's a challenge. I mean, it's to stay on top of everything. And it's equal. So it's not biased to just missing admissions or just missing discharges. Both are being missed. And I know we've been doing some projects with some hospitals, and the time from the decision on discharge to the actual discharge is a narrowing interval, right? It's down to hours sometimes. So how these processes get built in is important. The change scores, so these are in terms of actually monitoring the outcomes and knowing what's happening and how to, where the opportunities are for improvement. I think looking at these change scores within your organizations and then comparing to your benchmark organizations, your peer comparators, to understand what those change scores are. So the first two columns here show the average. These are the scales, so this is composites of several items. I believe there's 6 or I think 7 in the ADL composite, which is around self-care. You're all familiar with these, I think. So the mean score on admission, and then the mean score at discharge, and then we show whether there was an improvement or a loss in these. in terms of individuals' function, bladder continence, the average scores on admission and discharge. And then we also show the percent improvement. So the provincial average, you'll have your own hospital's report. This is provincial results here. We have your own hospital's report showing the percent change among your clients, but the benchmarks here are shown for small hospitals. The numbers should actually have a percentage on them in the middle group, so that's in the ADL composite 25th percentile, that's 31% improvement in ADL while the individual was in the hospital. That's the lower quartile, and then the median was 41% improvement, and the upper quartile being 45%. And so we show them both for the small hospitals and for the large hospitals. As we have more and more sites come on, we may actually have more refined views of benchmark organizations. And I work in long-term care sometimes, and I do know that there are collaborators that get collaboratives of groups of hospitals that get together and actually compare their individual results, which can also be very useful. And then we see sort of these improvements over time. So I took a look at these results, and they are very, very close to what the results were last year that we had with the full year of data. Again, this is the most recent quarter, so this is what happened to individuals in your hospitals in the fall. In terms of change scores. So we see down the far right column is the average percent improvement across the entire province, and on almost all of the measures, except for the therapeutic self-care, they were fairly strong positive improvements, and they are all within just a few percentage points of what we found last year. So the areas I think of particular importance here are the areas around dyspnea and nausea. We showed them being very significant factors in terms of readmissions to hospital, with nausea being very strongly associated with readmissions within 3 and 7 days, and even up to 30 days last year, whereas dyspnea was associated with the more the 30 and 90-day readmission rates. So they're very, I think, also important in the discharge and knowing what can be done to improve them. A focus here on ADL decline. So declines in ADL functioning are associated with long lengths of acute stay are problematic. They're a real challenge, especially for older adults, particularly for older adults that decompensate during acute hospitalizations. And I think the new senior strategy coming forward also highlights this issue. In fact, it was Samir Sinha a couple of years ago in a conversation, a presentation that motivated me to kind of look at teasing this apart because of what he was seeing among patients in his hospital. And it's very important, I think, for senior-friendly hospitals in avoiding unnecessarily long-term care admissions. So people come in, they decompensate to the point where they can no longer return to home. And that's a real challenge in the health system, I think, for individuals. And it's potentially avoidable with good interventions and practices around mobilization. And I know a number of your hospitals are improving this aspect. And here's a way to monitor whether they're actually having, what kinds of differences those improvements are having over time. If we look at this graph shows the percent of patients in a hospital who declined in their ADL. So I showed overall there were improvements in ADL status, but if we look at the other side, what percent of individuals are declining in their ADL during a hospital stay? And we split this out by 2 categories. One is by age, being that older people we would expect to be more at risk, and also by length of stay. The longer somebody is sitting in a hospital, perhaps the less active they are. And the alarming thing is, the evidence seems to show it's about 5% decline a day for a geriatric resident, a geriatric patient in a hospital, that they'll see about a 5% decline per day in a hospital. So if you have somebody who's in a hospital for 31 days, that's a lot of decline. And so we see also the percentage of people who are declining goes up both with age and with length of stay. And it's quite significant. So people who are in our hospitals for even the mid-range, 15 to 30 days, which is not uncommon among older adults, for 66 to 79, I mean, it's 30% of them are declining. And that goes up to 35% and stays at about that level. So these, I think, are also practice areas that if you implement a mobility program within the organization, you should see these numbers drop. And you should also see the numbers in the actual ADL improvements improve. So here's, I think, where we both have what is a reasonable performance measure as well as a quality improvement tool. So a new addition is a focus on therapeutic self-care. So we are advancing the report each year in what we can provide to you and where we think areas of focus. So we did actually include that ADL last year for the first time, and it was the first time we started looking at something that wasn't just an average change score. And I think it's an important value add. So this year, given some of the research that we had around therapeutic self-care and importance, the scale has changed a little bit, but what we had before was that a 1-point improvement in the therapeutic self-care score was associated with a 10% reduction in readmissions to acute care. So we found this to be quite a striking result and also to be important. Therapeutic self-care is critical for successful transition and management of conditions in the community. So as we think about groups like Health Links that are trying to focus on high-cost populations, keeping them in the community after a hospitalization or avoiding a hospitalization, self-management is quite key, and therapeutic self-care is an essential component of self-management. Teach back in hospitals is an effective and appropriate means of improving patient therapeutic self-care, and there's a lot of this activity going on. And I think it would be interesting to hear organizations' experiences in ways to improve therapeutic self-care in terms of what organizations are doing around this area. It's a challenge and it's very important, right? We're going to highlight this in the report, and here's where the audience participation, I am going to ask for a show of hands, at least if not voices, and I would actually prefer voices, on different ways that we could actually display the data for this. So the first thing is to look at the questions that are up. So most of you are quite aware of these, and we try to get all of them on one slide, so the print's a little bit smaller. But these, I think you're aware that these are about individuals' knowledge about how to manage their medications. Absolutely key. Almost always medications are changing on admission and discharge, hence the need for strong discharge planning and the emphasis on medication reconciliation on admission and discharge. Part of that is not only knowing that the patient has the right meds, but knowing that they know what their meds are and what they're for and how to improve their own management. Why they're taking those meds, what symptoms and signs to watch for. So this is, historically in Ontario, we've done very, very poorly on having individuals actually know that when they left the hospital, what were the signs and symptoms that they should be watching for and knowing what to do under those circumstances. And this gets at those questions. And ability to carry out treatments and manage your symptoms. It's an indicator towards that self-management. And then everyday things, and then knowing who to call in case of an emergency, right? So these are essential skills that individuals have. So when individuals are asked these questions, they're asked to rate them. Do you have this? Do you know what to do? And the answer is not at all, somewhat, or very much. And I think we would want pretty well everybody to be very much. I think there would be exceptions in areas of cognitive impairment, which might be challenging to actually assess. But other than that, I think we want everybody at the, yes, I know when I leave this organization what it is that I need to do. There are admission scores and discharge scores. So I'm going to put up 3 different ways of looking at these. So one is across these different indicators. So the top left corner, knowledge of medications. So knowing what medications they're taking. The admission scores make up the left column, so where people were 0, 1, or 2, that being not at all, somewhat, and very much on the left side. And then across the rows, across the columns, we see the scores on discharge. So in the top left corner there, 4.5%. This is percent of residents, and this is over the entire study period that we have data for. I don't think it's 2006 though, because this would just be the last 1 year of data. 4.5% came in saying, no, I don't know at all how to take my meds on admission. And when they left, they said, I still don't know at all how to take my medications. The most prevalent area is in the bottom right corner, which is 67% of people coming into hospital said, very much I know how to take my medications, or I know what my medications are, and walked out of the hospital also saying, very much I know what my medications are. But you can see that there are areas of improvement where people have gone from lower scores 0 and 1 and gone up to 1, or from 1 to 2. So there's areas where there have been effective interventions in the hospital. That's the only explanation I have, that have increased people's knowledge of their medications and across here. But there are also a smaller subset who came in actually with a reasonable knowledge, and when they left, they had lower. So actually the bottom left corner of this top chart, it's only 1%. But for some reason, 1% of people came into the hospital saying, I very much know what my medications are, and they walked out of the hospital saying, I have no idea what my medications are. So, but clearly, room for improvements. Those people are going to have a really hard time managing the community. And this is across all of these scales, right? So the reason for medications, taking medications. So do you know how to take your medications? That's actually the highest score here in terms of the number of people walking out. They don't know what they're for, but they know how to take them. I think that that's a partially in the right direction. We want people to know how to take their meds, but I think we also want them to know a little bit about what they're for and how to manage and what symptoms to watch for. So I think these are very instructive items in terms of being able to improve quality. So again here, carrying out symptoms, similar questions. And now here, do you know who to contact in case of emergency? That's the bottom right corner over here. So this is the highest achieving indicator. So most people know who to contact. So we're conveying that information out, which is very good. So one of the things, I've just put this up on the top right corner there, is if we think about areas that are, where are we doing well, where do we need to be a little concerned, and where do we need to be a lot concerned? Some people like the idea of a traffic light system. Green is good, amber is like, watch out, red is like, wow, really pay attention, focus, and figure out what we're doing. So one way we could do this, we could use these tables, and I'm going to present 2 other ways soon, so keep these in mind, would be sort of just boxes like this, which allow you to see the specific improvements or losses. And they could be highlighted in areas that make it a little more visibly highlight your attention into certain areas. I think if you do this too much, it looks a little bit too much like a pizza parlor, but you could tell me if you like the color or not like the color. We can do it one way or the other. The tables being, I think this is actually the most information that we can give you out of these scales. Another way of looking at this is just to look at the improvements over time. So we could take the difference of the discharge minus the admission, and we could say, if somebody left, what was their score, and how much was that different from the people on admission? And so the scores range from 0 to 2 on both scales. So on the difference from admission to discharge is either improving or getting worse. And so this would be, most people are staying the same. So most people come in and leave. These are all the they'd be the diagonal columns. So you can see they're the most prevalent columns in most cases, are that make up, the sum of those diagonals make up that middle area, which is people didn't change. And then the bottom area is people who walked out with less knowledge. And this is for each individual measure, and then where there's significant losses. And then up top, at the top of the graph, you see where the most improvements are. The numbers in the bars represent the percent of assessed patients, where we have both the admission and discharge assessment. And then this is for each measure, knowledge of medications, reason for medications, taking them, and then it's more about the treatments and an ability to manage in the community. We've put in here in the very bottom the percent of individuals who walked out of the hospital at level 2, which is where we'd want people. So the bottom 79%, 79%, 85%, that's the people discharged who said, very much, I know what to do. And I think that's sort of the performance measure idea, while we have opportunities for seeing how do we make that move, how do we move that one. So this is another way of looking at the data. And then finally, this would be, if we just look at, for each of the medications, so now I'm only showing 4 of them, knowledge of medications, reason for medications, able to take them, and able to notice symptoms. We have the distribution on admission and then the distribution on discharge. This tells you at the population level. It doesn't tell you about individual changes. The previous 2 graphs showed you about individual changes in some way. This just says how many people were walking out for each individual measure at each of the levels, red being not at all, yellow being somewhat, and green being very much. And we would also put, I think, percentage right in these bars as we did on the previous ones. They're not here because I did this instead of Dorina. So this is another way of looking at these. So I'm going to, here's your opportunity to give some feedback here. So across 3 areas, and so there were 3 approaches to looking at this. Tables, and we can do multiples if it's particularly useful, but what's most informative? Tables like this, a chart like this that shows the entire range, plus and minus, or this one that shows what the actual levels were on admission and on discharge. So I'm going to come back for a vote on this, because we are going to choose one of these, and it's better that you choose than we choose. So on this one, who thinks that the tables like this are actually the best way to present this information out? And hold them high, because I can't see too far, right? Good, good, so 1. Okay, that gives us a bit of a picture. Who thinks that this way is the best way to present this information, which is the change scores? Wow, we're going to have a tiebreaker after, because that's pretty close on those 2. And then finally, who thinks that this way is the best way? Okay, I think we have a slight winner. Hands up straight so I can see. Okay, so I'm going to go back through this one more time in case it's just taking people a little while to stretch. I think right on that one, I was seeing more hands for this. We're going to take your input. And then perhaps people might have a reason for that. So these tables, who thinks that these tables are actually the best way to present this information? Out. Okay. And these change bars. Okay, and finally, the actual rates on admission and on discharge. Yeah, it's not a huge majority, but I think the last one wins. Yeah, so okay, which is informative and I think quite useful. So knowing where you're at, I think a bit of a performance measure on the outcomes there. The last comment I would have then, I appreciate your attention here, is I think this is a great opportunity to have information that helps the patient and increase value. And I think the more it's used, the more value it is to you. The more coverage there is in your organizations, the more value it is to you. The more you can ensure that it's representative of all of your patients. So thanks very much.